Welcome everyone. I see some familiar faces. Thanks to everyone for joining for this Ask Me Anything. My name is Josh Sommer. I am co-founder and executive director of the Chordoma Foundation, and I'm joined today by our director of patient services, Shannon Lozinsky, as well as a few other members of our team, Sarah Nick, our chief of staff, Kimberly DeHasseth, and Danny Pike. And Sarah is going to be emceeing today, fielding questions, a number of questions that were submitted online. And in particular, this is really meant to be a live and interactive Ask Me Anything. So as questions arise, Sarah will call on you. I'm just going to go ahead and get started here with some housekeeping. A quick note, this meeting is going to be recorded. So if there's anything that you don't want to have recorded, including your face, your voice, I would just recommend keeping your video off and your microphone on mute if you don't want to be recorded. But otherwise, very much encourage everyone to participate. So keep your video on. It's always really nice to see faces. But additionally, if anyone misses anything or wants to come back to anything that was discussed in more detail, this will be up on YouTube pretty shortly. The way it'll work is that if you have a question, there is a button down at the bottom of your screen. It looks like a little hand. You click the button to raise your hand, and Sarah will call on you. At the time that you are called on, that would be a good time to unmute yourself. But other than that, please keep yourself on mute just so there aren't any interruptions from background noise. And if you would prefer to ask your question off camera or not via voice, you can type your question into the chat and Sarah will be monitoring that and will feed questions to us as they come in. We have an hour scheduled. However, we don't have a hard stop. We want to make sure that everyone gets what you'd like out of this. And so we will just keep going as long as there are questions. Please don't hesitate. Please don't hold back. We are here to answer any and all questions that you might have. Really, nothing is off limits. The only thing that I'll say is that Shannon and I are not medical professionals. We cannot provide medical advice. No one at the foundation can. So if there's any questions that start to veer towards looking for specific advice around your particular case, we're going to just suggest that you speak with an experienced Chordoma physician. And if anyone has any questions or needs assistance in finding experienced physicians, you can look on our website or you can contact our patient navigators at support@chordoma.org. And then as always, our team is here. Should you need anything after the webinar, feel free to get in touch with us. I'm going to go ahead and stop sharing my screen and we can dive right into questions. So Sarah, over to you.
Yeah, thanks, Josh. Great introduction. Thank you, everybody, for being here. It's so nice to see this full house and see all your faces today. We got quite a few questions offline. Again, use the raise hand tool, and I'll get to you in a moment, but I'm going to start with some of those offline questions. So, Josh, this first one can be for you. A patient named Fabio has asked, do you expect that new clinical trial drugs like cetuximab will be tested in Italy or other countries in Europe? And how would you foresee that happening?
Absolutely. So there's currently a trial that has just wrapped up in Europe, 3 sites in Italy, in the Netherlands, and the UK, testing a related drug, afatinib. And the results of that trial should be published in the next several months, or certainly in the next year. As new therapeutic concepts are identified, we have a vetting process that involves our medical and scientific advisory board. It's really important, given scarce resources and a limited number of patients, that the trials that are put forward are really well justified. And certainly from the standpoint of those of us who might need to participate in trials, I think we want to know that they are based upon sound scientific foundation, that they're well designed, et cetera. And so when trials meet those criteria, then the next step is figuring out how best to get them done. And that might include running the trial here in the US. It might include running the trial in Europe. There's a number of different factors that go into that, some of which have to do with the availability of drug. Some of it has to do with the particular interest of investigators who are interested in running such a trial. But absolutely, our medical advisory board is comprised of experts from around the world. And our intent is for trials to be started on both sides of the Atlantic and perhaps even eventually in other countries as well.
Wonderful. Thanks, Josh. I actually have a second question from the same individual, little bit of a different one. What goal has the Chordoma Foundation set for itself in terms of how many years you think it could take to find drugs that will totally take care of this disease?
That's a really good question, and I wish that I had a crystal ball. We can't prophesize. If we knew the answer to that question, we would have a cure. However, I think what is a great source of encouragement for me is that the pace of progress is increasing dramatically compared to when the foundation started, compared to even just a few years ago. And there's a number of things that are contributing to that. So first and foremost, we have a wonderful network of Chordoma clinicians who are eager to bring forward clinical trials when there are well-justified therapeutic concepts. We have a tremendous network within the patient community and the patient services that Shannon leads, so that when trials are started, patients can learn about them and those trials can accrue quickly. A major barrier to starting and running clinical trials for rare cancers like chordoma is that it's oftentimes very, very slow for those trials to accrue, and therefore you don't get an answer for a long period of time. But looking further up the pipeline, so to speak, we've learned so much about the biology of the disease in recent years, and that knowledge is pointing to a number of different therapeutic options, both repurposing options, so it's basically drugs that already have been developed for other cancers or other diseases that could be applied to chordoma, as well as an important therapeutic target for chordoma, as well as potentially for other cancers that has not yet been drugged. There aren't drugs for it yet, and people may have heard about this target called brachyury. So we're working in parallel to repurpose existing drugs, as well as to facilitate the development of drugs targeting brachyury. And there are a number of steps we've taken in recent years to try to accelerate both of those processes. And that includes things like making sure that researchers have the basic materials that they need: tumor tissue, cell lines, animal models, making it very easy to test concepts in those models. But in particular, in the last 18 months, we've gone a step further. And this is the biggest thing yet we've done to condense the timeline from discovering some new aspect of chordoma biology to clinical trial, and that is creating our own lab, which allows us to very nimbly and rapidly generate the data packages that are needed to justify clinical trials. So to convince and to provide rationale for companies to contribute drug to support those trials, in some cases for companies to sponsor those trials, to convince investigators that this is a trial that's worth running, and to provide the necessary justification to ethics boards, to IRBs, that indeed that would be a trial that is suitable to support. So the speed and efficiency gains that the lab is providing are just almost hard to quantify. It is just night and day what we've been able to do in the lab compared to what we've seen in years prior to the lab being available. And so because of that, there are a number of new repurposing trials that are coming down the pike, as well as in the next several years, very likely drugs targeting brachyury that will move into the clinic.
Awesome. Thank you. Thank you, Fabio. I see that you're here today. Thank you for your questions. We can bring it into the room now. Richard, you've had your hand raised. Why don't you go ahead, please?
Hi. Okay. Well, one of the media things is, I don't know if this is a good question or not, but how can we tell the insurance companies that after we have the operation, like I'm Sagro, that we need extensive therapy, that, not just more than, maybe years of therapy. How can we get that information out to these insurance companies and to the people? Like, say, we go to an outside the company, like for example, I'm going to Jag One, and I got my script from my doctor, and they informed me that, well, this facility doesn't take my insurance anymore. You got to go to another facility. How can we get that information out to these places that do the rehab and say that, hey, this is a valid disease or something like that, and they need rehab and stuff like that. Is that a good question, or what do you think, Josh?
Well, I'm going to turn it over to Shannon, because this is a question that she and our navigator Andrea get on a really regular basis. So Shannon's probably best equipped to answer it.
Yeah, sure. And it is a good question, Richard. And in the United States, with insurance providers, a difficulty is that they're all so different, and there are so many plans, and there's, it varies so much, which I know that I'm sure that you've run into. And it's hard to know. There isn't really necessarily a blanket way to handle something like this, but I think we do have a really great resource within the foundation in our patient navigators. And Andrea is the patient navigator who works with people within the United States. And so Andrea can help you. Richard, if you were to contact Andrea, for example, you could tell her more specifics about your insurance company, and she could try to help you figure out what it is that we could provide to the insurance company. Because with rare diseases kind of across the board, if insurance companies don't understand what they're dealing with, they might not know, what patients need after surgery, or which I think is what I'm understanding you're asking about, is like with rehab, physical therapy, follow-up, all of the things that are the quality of life, daily living kinds of things that you deal with, that this is important and it's necessary. And it can, sometimes it requires a certain information from a doctor that could help with that insurance approval. It could be published information in medical papers. It really depends on what your situation is and what's needed. But Andrea is very good with that, and we can certainly help support you in trying to figure out what your insurance company needs for whatever approval it is that you're seeking. I wish there was a better answer for how do we get insurance companies to act better in general. But I think that right now it's an individualized thing. And so we're glad that we can have a patient navigator available to you to help you with your situation.
Okay, thank you. Thank you.
I would just add to that, if you haven't seen already, there on our website, you can find published treatment guidelines. So these are like published in high profile journals. They're peer reviewed. They have over 50 or so of the leading Chordoma physicians who are authors. And so I think what we found is that they carry a lot of weight with insurance companies, et cetera. So that's like low-hanging fruit if you haven't taken a look at those or passed those along already. But I think, as Shannon said, it's really pretty context dependent and case by case in terms of what information would justify or satisfy the needs of your particular insurance company.
Thank you.
Perfect. Thank you, Richard. And I just posted a link to those treatment guidelines that Josh is referencing in the chat. We have a great question that actually came in via email from Adrian. Adrian, I see that you're here today. Would you like me to ask it, or would you like to ask it yourself?
You can ask it, that's fine.
Okay, awesome. Thank you. So Adrian's question is, and this is for Josh, anecdotally, many women who are diagnosed with chordoma 6 or 7 years after their pregnancies find they have high prolactin levels later on in life. Have there been any studies suggesting the imbalance of hormones in women when they are pregnant might be the trigger for the initial growth of chordoma in some women?
It's a fascinating question, fascinating observation. I think the short answer is there's nothing published that I'm aware of. However, this is exactly the type of question that the natural history study that's ongoing at the National Cancer Institute is intended to answer. And so for anyone who is unfamiliar with this study, essentially the idea is there's so much about the patient journey, whether it be occurrences, risk factors, et cetera, that might have occurred prior to diagnosis or experiences after diagnosis, that we can only learn about by aggregating the experiences of large numbers of patients. And this is it requires a really massive undertaking, a lot of data gathering, a lot of expert interpretation of medical records. And we're so fortunate that the National Cancer Institute has basically invested just a tremendous amount of time and resources in setting up such a study specifically for chordoma. And so I see that Shannon has just popped a link into the chat, but I would really encourage anyone who is potentially interested in learning more to check out that link. And if you think it's something that you'd be interested in participating in, to go ahead and reach out and sign up. That's the only way we're going to answer this question, is by aggregating the experiences of large numbers of patients. And I think we can pass along this observation or this hypothesis and see if it's something that they observe in that cohort. I haven't heard anything from them yet, or from others yet, about that, but we don't know until we look.
Thanks. Adrienne, you want to go ahead? Yeah.
I just wanted to say that I mentioned it to the NIH, the doctor that I was speaking with, and I just want to echo your suggestion that the more people that sign up for this study, the larger number we can take that information from. But she thought that the question itself was really interesting. And so, it also prompted me to think about young women who are diagnosed early when they strike in puberty, and if it's some hormonal correlation. I don't know. And I don't know for men what that would be, but a lot of us were talking about it over the years, about prolactin, and talking about, I was diagnosed 6-7 years after my pregnancy. So anyway, thank you.
It's fascinating. I mean, there is
fascinating.
Unquestionably, there are some kind of sex-specific aspects of chordoma biology, simply because we know that there is a 2-to-1 male predilection. But the interesting thing is, in the skull base, it's flipped. There's a slight female predilection in the skull base. So clearly some sort of biological differences, and might that have to do with hormone changes throughout life? That's a really interesting question.
Yeah. Thank you, Adrienne.
I wanted to
go ahead.
I just wanted to say, this is sort of related to it, that with the hormone levels for skull-based patients in particular, is that radiation treatment can affect your pituitary, almost certainly will, and endocrine system function. And so I don't think that is your exact question, Adrienne, but I just thought this could be a good time to also mention the fact that radiation for skull-based patients can cause hormonal changes. And so it's really important to see an endocrinologist and possibly a neuroendocrinologist, which I think, is not usually ever left out of any skull-based patients' follow-up care, but it's an important thing to keep an eye on and watch for, and really get those experts who know about how to deal with things like this, to make sure that your hormones can be balanced appropriately so you can live a good life.
Thank you, Shannon. Shannon, this next one is also for you. I'm going to take one from the chat, and then Robert, I'll come over to you next. Karen asked in the chat, is there a protocol for care after 18 years of being chordoma free?
So Karen, first of all, congratulations on being 18 years chordoma free. I think people hearing those kind of stories, it gives everybody else so much hope. So that's awesome. But protocol wise, the official guidelines for annual scans and things like that, they say for the wording is for at least 15 years. And they don't really go past that for reasons I'm not totally sure about, but I think it becomes unclear after that. There's not enough data to support exactly what to do after that length of time. But what we know is that there have been patients whose, unfortunately, the chordoma has come back after 20 years. You know, that if patients are living that long, that it's possible, which is unfortunate. But the best thing to do is to keep doing those annual scans so that you can be sure to catch anything that might be happening. If we're talking about individuals who've dealt with recurrences, not just had the initial diagnosis and treatment and then been tumor free since then, if there's been recurrences, then that schedule changes, but it should definitely be closely watched and decisions made about whether scans happen every 6 months or every year. Those decisions made with your medical team, so that you can always be sure just to be keeping an eye out, because it can, unfortunately, we know that there is no end date of when it could decide to return. So being careful to be watchful is a really good thing.
Mm-hmm. Thank you, Shannon. Let's see, Robert, you have your hand raised. You want to come off mute and ask your question, please? Oh, okay. We will, Robert, if you change your mind, just raise your hand again and I'll come back to you. Richard, do you want to ask something else?
Yes, this has to do with radiation versus non-radiation. I don't know if Josh can answer this question, but I just want to digress and say my oldest brother, he had colon cancer, and what they did to him was they gave him chemo to reduce the tumor, and then they did the operation, right? And that gave him a couple of more years of his life. He passed away. But anyway, I think with this chordoma thing, you got to think about it in a different way, where this, playing this radiation, maybe, I mean, I've heard some situations where they play the radiation to reduce it, and then they take it out and stuff like that. But and for example, my doctor is Dr. Daniel Schuber, and he believes in taking wide margins, right? And then as a second resort, if it recurs, using radiation. And he even told me that each surgeon has their own egos, each way of doing stuff. So so my question is basically, is there a general thing that, general steps to take, like for sacrum or for the other types of chordomas, general guidelines of how to operate and stuff like that? Because I mean, it's different from your regular cancer, this thing. So, I'm in the camp where, all right, take the wide margins, and though a lot of things are going to be affected, but some people say do the radiation first and then do the operation. And like every Tuesday of the month, we had these discussions, chordoma discussions. We had some interesting discussions. Like some people just get the radiation, they don't get the surgery. Some people say just take the wide margins, and some people get the radiation and then the surgery. But I think if you get the radiation and the surgery, then I don't know if you can take the radiation again. So,
yeah,
I mean,
it's a great question. So I think what you're highlighting is a important set of questions that remain unanswered. We don't actually know. There's never been a head-to-head prospective trial comparing surgery versus radiation or the combination thereof. That trial is ongoing right now in Europe. There's, I think it's about 17 different sites in Europe that are running a prospective study to answer this exact question. Right now, all we have to go on is case series at individual institutions. And there are some institutions that show pretty good results with surgery alone, with wide surgical margins, with even radiation alone or the combination thereof. There seems to be a trend towards the best outcomes with surgery plus radiation, and therefore If you look at the consensus guidelines, that's what's reflected there in the consensus guidelines. That's probably what most clinicians are going to recommend. But it really comes down, it's case by case. It depends so much upon your individual anatomy, where the tumor is located, what sort of surgery is possible, and then what sort of collateral damage you might expect from that surgery. So there's a big difference in the sacrum for a low sacral tumor versus a high sacral tumor, and this is where the expertise and the experience of a highly experienced care team really comes into play. It's going to be very difficult, really, I think, even with the prospective trial, to make a blanket recommendation for all sacral patients. I think we're lucky that we have both surgery and radiation as effective tools in the toolbox, and then it's up to the expert clinicians, based upon the data that exists and their understanding and capabilities, to apply those tools to the specific context of each individual patient. The only thing I'll add to that is that there are additional tools that are being added to the toolbox. And so one of those in recent years has been surgery to create space between the tumor or tissue that needs to be radiated and tissues at risk. So, for example, the rectum. So there's been some kind of pioneering efforts to spare those critical structures by adding some physical space using actually silicone implants. So that's one example. Another example, you talked about your brother, and I'm sorry to hear that he passed. But the idea of doing chemotherapy prior to surgery to try to reduce the tumor volume, that's definitely a concept that has been discussed. That is, a worthy goal for the Chordoma research and clinical community. The problem is we don't yet have drugs. We don't have chemotherapies that can reliably shrink chordoma tumors. If and when those are discovered, and every confidence that they will be discovered in the coming years, most likely they're going to first be applied or tested in the more advanced disease settings. So patients who have had a recurrence or who have had multiple recurrences, but eventually those therapies will get applied in the initial or primary disease setting. And you could envision a situation where patients, you find out that you have a large sacral tumor. Maybe it's either inoperable or you might expect significant morbidity or side effects as a result of surgery or radiation. Perhaps you try a systemic therapy, reduce the volume of the tumor, and therefore make the surgery much less risky, or increase your odds of obtaining a complete resection with wide margins. That is definitely an ideal that we're aiming towards. And so I think in the coming years, we will see trials in that setting, but we're not there yet. We first need to see that there is a drug or drugs that can reliably shrink chordoma tumors in any setting before it will make sense to test it in that upfront setting.
I think another thing that's important to think about here is as Josh mentioned, the expertise of your surgeon, the opinions of your surgeon based on your particular case. Also, what a radiation oncologist might have to say about what their treatment could provide if you were to not have surgery. But the patient's preferences are important as well. When we're talking about sacral tumors, especially the higher ones, S1, S2, S3, there's significant side effects that come along with removing those surgically. And that sometimes it seems like, well, surgery has to be done because the tumor has to come out of my body. But if you're not okay with what that means for your quality of life, then you might very well consider only doing radiation, and depending on your age and all kinds of different things that go into that as well, that patients' preference for their lives and is important as well. And there may be trade-offs there, or just people decide one way or the other, surgery, radiation, some surgery, then radiation, just depending on what's important to them. And that those are very reasonable things to consider when making those decisions as well.
Thank you.
Thank you, Shannon. Thank you, Richard. I will bring another question in from the chat. Shannon, this would probably be for you. This is from Lindsay. She says, I was diagnosed with chordoma in July and had a biopsy and surgery to remove it by the same neurosurgeon that diagnosed me. I knew nothing about it at the time and was not familiar with chordoma. I have had no radiation. Is this something I should be concerned about? And what should I do moving forward?
Is the question is not having radiation the concern? I don't see the question, Sarah, so I was going to read it myself, but I'm missing it.
No, that's okay. I think and Lindsay, if you're here, you can feel free to come off mute and weigh in. But I think it's more about if you are treated by a chordoma, or excuse me, by a neurosurgeon who is not a chordoma expert, how would you go about answering a question like whether to pursue radiation?
Sure. Yeah. Okay. Got it. It's a really good question. So I think that a radiation oncologist, involving a radiation oncologist in the discussion is important, and certainly now that you know that it is chordoma for sure, that looking for a radiation oncologist who has experience treating skull-based chordoma is important, and if at any point it seems that a surgical opinion might be important within the decision about radiation, I think that you can involve your original surgeon. It wouldn't be harmful in any way probably to also involve a surgeon who has a lot of experience with chordoma. It depends on, what the extent of the resection was, how much tumor they were able to remove to help make those decisions about radiation. If there's any tumor remaining for skull-based patients, really for any patients, if there's any tumor remaining after surgery, radiation is really always recommended, because without radiation, that leftover tumor will start to grow again. So, those are the kind of things to consider with radiation decisions. And with skull-based in particular, there is a panel that can be done, a special kind of pathology testing that can be done that can determine some factors about your tumor that could help you make radiation decisions. And I won't go into a big description of it here because it's all on our website, and we'll get the link to that page into the chat in just a moment. But that could also help if you've had a complete resection. There's no tumor remaining that can be seen on scans. There is the neurosurgeons are starting to think now, and the radiation oncologists, does every skull-based patient have to have radiation if all of the tumor was removed? And we're starting down that path now. There's more research to be done, but there are some doctors who are relying on this test to help patients make those decisions. So if it's appropriate for her, then that could be a good thing to consider and talk with her doctors about as well. And please, if you need any help with this, our patient navigator Andrea can definitely help with that and get you names of radiation oncologists and anything else that's needed.
Thank you, Shannon. Abian, you've been so patient with your hand raised. Go ahead, please.
Hi, good afternoon from Spain. My question is, how, in your experience, how is immunotherapy working in sacral chordoma? I'm going through pembrolizumab. I think in the US it's called Keytruda or something like that, pembrolizumab. I had surgery and then went through radiation, proton therapy, and 4 months after radiation, I had recurrence, and now going through immunotherapy. So I don't know if any of you know how is it working immunotherapy.
Yeah, it's a good question. I'm sorry to hear about your recurrence. Pembrolizumab in particular was tested in a phase 2 trial in France, and the results were just published earlier this year. The response rate was somewhere between 10 and 15%. I think the exact number, Shannon, maybe you have it off the top of your head. I think it was like 14%. So that means 14% of patients had their tumor shrink significantly. However, a larger proportion of patients had their tumor stabilize. So I think among the existing systemic therapies, that's probably the one, or among the handful that are showing the most efficacy in published clinical trials. So I think, very reasonable for that to be, the approach that your oncologists have recommended, and certainly hope that provides, long-term control. There are other types of immunotherapies as well, so that might not be the only option. And I think the most important thing in this particular case is being seen by medical oncologists who have experience treating chordoma. And we're aware of several in Spain, and they're, maybe you're being treated by them already, but they're in our doctor directory, and they would be very well positioned to guide you and share the latest in terms of systemic therapies that are offering benefit to patients.
Yeah, thank you, Josh. Yes, Kimberly addressed me to some doctors in Madrid, in Barcelona, here in Spain. Thank you very much. Is there in case of pembrolizumab does not show results, is there any second line treatment that could offer reasonable some good results, a second line treatment?
Yeah, if you look at what's published and what we're aware of, I think in general there is the most evidence for EGFR inhibitors, a class of drug called EGFR inhibitors, being active in probably a similar proportion of chordoma patients as pembro. But I say probably because that data is still emerging. And then if you look beyond that, there's a number of other what's called tyrosine kinase inhibitors. So these are things like imatinib or sunitinib, et cetera. The response rates there are lower, but there are patients who have benefited. And then there are a number of emerging therapeutic targets for which there's very strong preclinical evidence. In fact, the preclinical evidence is in some ways even stronger than EGFR inhibitors or checkpoint inhibitors, et cetera. And those are moving into clinical trials. And that is, if you go to our website, and maybe we can put this in the chat, there's a drug therapy list that provides all those different targets and all those different therapies. But one that I would highlight that is, I think, showing a great deal of promise is called SHP2 inhibitors, SHP2 inhibitors. And there's some clinical trials that are open. I don't know if there are sites in Europe, but that's something that we could look into. And then there's other options as well. But I think the best bet would be to be under the care of an experienced medical oncologist, and they would be well equipped to guide you in that respect.
Thank you very much, you all. Thank you. I really appreciate that.
Absolutely.
Yeah, thank you so much for your question. Here's a question from Christina that might be tricky to answer, but maybe Josh or Shannon, you'll have some ideas. So the question is essentially, if a patient is told that their clival chordoma was resected 100% from an operation, but then a couple of MRIs later, they're actually told that there's a 75% chance of a nugget size chordoma tumor being left over. How could that have happened? What could have led to the change in those two outcomes that this patient was told?
Yeah, well, I guess to some extent I can speak to this from personal experience. So oftentimes after surgery, your anatomy changes dramatically, and it can sometimes be difficult to determine whether a particular feature on your MRI scan is residual tumor, is it scar tissue, is it something else. And so, similarly in my own case, I was initially told that I had a complete resection. There was really no areas of concern. But several years after that initial surgery, all of a sudden, and I think another thing that changed over that period of time is that the MRI machines became more powerful and the imaging techniques changed. And so structures that might have been smaller or smaller than basically the limit of detection might have become more apparent as imaging techniques improved. So yeah, I basically experienced the same thing. I was told that I had a complete resection. Over the years, there were spots that were identified as areas of concern. They were followed over the years, but interestingly, those areas of concern didn't really change much over the, let's call it 10 years that they were followed. Then, I guess going back to a previous question about, what is it possible for chordoma to recur after 15 years? Should you continue to be imaged? So after 16 years, indeed, a new spot showed up that, to make a long story short, turned out to be a recurrence. So I had surgery last year to remove that. And while they were doing the surgery to remove the new spot, they took advantage of the opportunity to go after this additional spot of concern that was identified several years prior. And indeed, that did turn out to be tumor. However, it was growing at a almost imperceptible pace. And then indeed, there was a third spot that was identified that wasn't visible on MRI, but that was visible when they were in there and doing the operation. So it can be jarring and it can be disappointing, but I think there's perhaps multiple valid reasons for why it can occur. I think it never hurts to get second opinions on your scans. And again, I can speak to that from personal experience as well. The most recent recurrence was not easy to spot and very, very nearly was missed. So getting multiple eyes on it is really valuable.
Okay, thank you. Question from Tiffany that I could see either Shannon or Josh or both of you being able to answer. Any tips on how to stay hopeful or positive after just finding out about the diagnosis? And what are the best ways to support the family member who has it during their journey to find the best medical teams and during their surgery recovery?
Yeah, well, I can speak from personal experience, and then Shannon, who's spoken with thousands of others, I'm sure has more to add. And I'll just preface this by saying I'm sure that everyone is different. So I don't want in any way for my own coping mechanism, my own experience to imply that that is the right way. But I think personally, demystifying the disease through learning as much as I could was, I think, a big step towards alleviating anxiety and feeling like I had a handle on what I was facing. And I think the second step was feeling like I had some trying to find ways to have some agency in affecting my outcome. And I think that started with, being an educated patient and getting a good handle on my own care, but then extended to the work of the foundation. And I think in a way, I hesitate to say a gift because I don't know that any part of of having chordoma is a gift. But if there is a silver lining, if there is a gift to having chordoma, it's that we have time. Unlike other diseases where the trajectory or the progression of the disease is very fast, and you might not have a lot of years for science to advance or progress to be made. Many of us have the luxury of time. And because of many in this community who have come together through the work of the foundation, we've been able to make progress at an increasingly rapid pace, and that is accelerating, and the pace, progress is snowballing. And so the ability that each of us now today that we have to influence the outcome, of those of us who are alive today and change the standard of care for this disease is far greater than 5 years ago, 10 years ago, or 15 years ago, and it's only going to increase as time goes on. So I think every one of us has the ability in ways big and small to influence the trajectory of this disease for all of us. And I think as a patient and someone who stands to benefit from the advances that are being made, that to me is the biggest source of hope. And it's just tremendously heartening to see how many others in this community have rallied behind this cause, who have come together, pooled our efforts, pooled our resources, and together allowed for progress that would otherwise have never been possible. So that's, I'm sure, not a panacea. It's, maybe there are very legitimate additional concerns and I'm sure additional sources of support or solace or comfort. But I think for me, it's just feeling a sense of agency and knowing that my effort and time and contributions can in some ways have a credible chance of changing the odds of outrunning this thing. Shannon, anything that you would add to that?
Yes, and I mean, I think those are really, really good thoughts. I think something that I have seen and our patient navigators have seen time and again for newly diagnosed patients is that there's such a huge difference between hearing the diagnosis and the time when they connect with a chordoma expert that they trust and can learn about a treatment plan. That once that is in place, it's so talking about very immediate concerns, and it sounds like your family member was just recently diagnosed and is still in the process of finding that medical team. Turning to our patient navigator, Andrea, if you're in the US, she will be glad to help get you or your family member connected to chordoma experts. And that can just be a sense of having that trust in the doctor and knowing there's a treatment plan. That can be really a good thing to hold on to. And then connecting with others who have recently been diagnosed, as Karen was 18 years ago. And you can we have an online community called Chordoma Connections that you can find through our website. That's free to join. It's a private community, so there's only chordoma patients and family members there. That is a great place to talk with others and just connect with people who know what chordoma is. Having a rare disease like chordoma can be very lonely and feel very isolating and scary when the people who are talking to you about it, even medical professionals, aren't really sure what it is. So finding those other people. We also have online virtual support groups every month. So there's a group for patients and there's also a group for caregivers, co-survivors, loved ones. And we meet over Zoom, and it's just a really great place for people to talk and come together. And there's also a private group for chordoma survivors and family members on Facebook. So any of those ways, those are all virtual ways, but sometimes that's the best we can do with it being so rare. And that connection is a really helpful way, not just for the patient, but for family as well, to know that you're not in this alone. So I really hope that Tiffany, that your family member will be able to take advantage of some of those things, and at the very least, if they haven't already, to get in touch with Andrea so she can help with the expert information.
Yeah, thank you, Shannon. Josh, thank you, Tiffany, for that good question, and we're here for you for sure. Question from Tim. Perhaps Shannon, you could start on this one. He says, I know there's some discussion and debate about biopsy. Are there times when biopsy is encouraged versus not? And what's the common practice for biopsy now? And does it differ depending on your tumor location, sacral versus skull base, et cetera?
Yeah, those are really good questions. And this is something that is included in those treatment guidelines that we were mentioning earlier, that Josh mentioned, of the group of 60 chordoma experts who came together and created the evidence-based treatment guidelines. And the reason why there is hesitation about biopsy is because chordoma is a type of tumor that can seed. So meaning if they go in for a biopsy, if tumor cells are pulled along the track of the biopsy needle, they can grow in that area. And so protecting from that is very important. Doctors who understand that that is a feature of chordoma and are doing a biopsy will take care to protect against that as much as possible. There are recommendations for well, let me back up just a little bit, because the recommendations do differ. For sacral tumors, biopsies are pretty much always recommended unless it's dangerous, because there are tumors in the sacrum that can look exactly like chordoma on imaging and are not chordoma, and they may be treated differently. So they won't want to go in for a surgery thinking it's another type of tumor. So they usually do the biopsy beforehand, similar with spinal chordomas, as long as it's safe. Skull-based chordomas can be very risky to biopsy, and so they don't typically biopsy them before surgery. It is done sometimes. So when I say that, if you have a skull-based chordoma and it was biopsy before surgery, that's not necessarily the wrong thing to do if a doctor who is experienced with chordoma decided that was the best thing to do. But usually the approach there is that for skull-based chordomas, the surgeon and the pathology team will approach the surgery as if it is chordoma. And the reason why you'd want to do that is because you want to take the whole tumor out while you're there. You don't want to take just some of it and come back later. It's really important, if it's chordoma, to get as much tumor as possible. And that may not be true for another benign tumor in the same location. You just want to get as much of it out as needed to relieve symptoms. But that would be the wrong approach for chordoma. So they're ready at the beginning of surgery to be able to take a biopsy of the tumor and have the pathologist look at it immediately, determine if it's chordoma, and then proceed with the surgery. So yes, they do differ, but there are guidelines for this, and they're pretty much standard for doctors who are experienced with chordoma, know they may be dealing with a chordoma, to follow those guidelines. And the link is in the chat, but I suppose we could put it back in if needed. So yes, it's a very good question, and one that comes up a lot for newly diagnosed patients.
Great, thanks, Shannon. Question in the chat from Robert. Are there any stats that show what the average number of years there are between proton therapy to the brain and resulting pituitary failure?
I think that there are some published case series. I don't know those numbers off the top of my head, but I think that an experienced any of the proton centers would be able to answer that question, I think, pretty easily. I think that my understanding is that it is a late effect, so typically manifests years after the initial treatment, but I think that it varies, and I know that the particular hormones that are affected might be a function of exactly where the radiation was delivered. Shannon, do you have any more specific information?
I don't have anything more specific as far as any evidence on the number of years. I think what I am aware of is in talking with neuroendocrinologists at places like UPMC in Pittsburgh in the United States that treat a lot of skull-based chordomas. An endocrinology, the testing and understanding your hormone levels through blood tests should be done before surgery and after surgery, and basically at every follow-up. So we don't necessarily know when they might occur, but the doctors should be looking for it every time that you have a follow-up. And in the first few years, that's sometimes every 3 months for the first year or so, and then every 6 months. And so those are getting tested regularly. But if you go on our website, you can learn about the symptoms that come along with endocrine dysfunction. And if you notice any of those symptoms, you should certainly contact your doctor to let them know that you've noticed these changes, so that they can see if they need to redo any tests and see if anything has changed. So it's sort of one of those, if we don't know exactly when it might occur, it's something to be on the lookout for anytime after you have radiation if you're a skull-based patient.
Great. Jack Dworkin asks, at least in the situations where a surgeon is experienced in chordoma, are there any protocols in place to make sure that they're using the most current biomarker testing of tumors? Is that being done automatically, or is that something patients need to know to ask for?
Yeah, I think that I don't think that it is routine yet. And so in particular, so one biomarker that's been used for a long time is called Ki-67. So that is basically the proliferative index of the tumor. What proportion of cells within the tumor at any given time are undergoing cell division. And that is pretty well correlated with aggressiveness. The more recently discovered biomarker that Shannon referenced earlier is a different type of test. It's what's called a FISH test. And that's basically looking for the loss of particular segments of DNA within the tumor. And that is correlated very strongly with outcome. So whether you're likely to have a recurrence over time, and in particular, it's correlated with benefit from radiation if you've had a complete resection. So if you haven't had a complete resection, as Shannon said, radiation is pretty much always going to be recommended. But if you've had a complete resection, there's some tumors that seem to benefit from radiation, and will definitely recur if radiation is not given. But there's another subset of tumors that seem to not really benefit from radiation, and maybe those patients ought to be spared from the potential side effects that come along with it.
And to be clear, that's skull-based patients.
Thank you, Shannon. Yes, we're just talking about skull-based patients right now. And so the evidence that supports what I've just mentioned, what Shannon shared, that's published, and maybe we could put a link to it in the chat. But it was published, it's based upon one center's experience, the University of Pittsburgh Medical Center. And there are about 150 patients that were included in this cohort. So that's a pretty decent cohort for chordoma, but as cancer goes, generally it's not a large cohort. And so before that test is going to be put into practice widely, there's several things that need to happen. First, it needs to be validated in a larger cohort, and it needs to be validated at more than just UPMC, more than one medical center. And we've just provided funding to a group that's led by UPMC, but also includes several other medical centers to validate this particular test across 1,000 tumors. And importantly, that's not just skull-based, but it also includes tumors of the spine and sacrum. And so the results of that study will tell us whether indeed the results are replicable across institutions and whether they're applicable across tumors of different anatomic locations. And that, I think, is from what we understand, is the information that's missing for this approach or this test to be widely adopted. So I think we can expect in the next several years, depending upon the results of that study, for that to be used more widely. However, in the meantime, if it's something that you as a patient are interested in, and I think certainly there's every reason to be interested in having that information, it's something to talk with your doctor about, and probably something you're going to have to ask for proactively. even though it is a relatively simple test, not every pathology department is going to be set up to do it. There's varying reasons for that, some of which have to do with kind of regulatory issues and accreditation, et cetera. And so if the particular pathology department where you're treated does not have the ability to do this test, there are several different sites where you can send your tumor and they can do it for you basically as a second opinion or as a service. Pittsburgh is one of those sites, but there's others as well. And if there's any questions about that, you can reach out to us and we can provide additional information.
I think the other something to touch on here and is that I'm not sure, Jack, if which kind of testing to talk about or you're asking about, but folks who've had recurrences or advanced disease may be thinking about other types of testing like genomic profiling and things like that as well to determine if there are any markers in your tumor that can be that can guide treatment with drug therapies. And there isn't a standard protocol on that being done. We see that it's not necessarily done in a standard fashion across the board. I think the more Chordoma experience a medical oncologist has, which is the type of doctor that would order a test like that, the more they treat Chordoma, I think the more likely they are to talk with you about that type of test and what it could do for you and whether or not you should have that done. But it's always something to ask your doctor about if you are at the stage where you're talking with a medical oncologist as part of the considering treatment and where to go next. Asking about molecular profiling is really important, and there's information on our website where you can learn about that as well. Those tests are improving all the time. Chordoma doesn't. They are standard practice for other types of cancers and really can help guide treatment. That's not always the case with Chordoma. It can be, but the way that Chordoma is often described is genomically quiet. So there aren't a lot of changes in Chordoma tumor cells that can be picked up by these types of tests right now. And so it doesn't always help. But you don't know that if you don't do the test. And so if the medical center offers it, if your insurance will cover it, if it's not a hardship for you to have the testing done, then it can be helpful. For folks who are newly diagnosed, we get a question a lot of, should I have my tumor tested now? And, in some ways that's a personal decision, but it's good to think about the fact that, with surgery and radiation often giving you years of no tumor growth, it may be a better decision to wait until you need a test like that if you aren't able to have surgery or radiation anymore, because your tumor may have changed, the testing may have changed. There's just a lot of things that can happen. But one thing you can do if you're newly diagnosed or you have a recurrence that can be treated with surgery and don't need drug therapies right now, you can talk with your surgeon about having your tumor stored in the appropriate fashion so that should you have another recurrence soon or anything else happens, you have some tumor available that you could send off to the companies, to the labs, to do this type of testing. So I know that that was kind of a lot of information. So obviously, if anyone would like to talk more about that, contact us. And also you can look at our website on the drug therapy and page in particular about that type of testing.
Yeah, I just want to add to that. There's a really important nuance, which unfortunately is oftentimes overlooked. And that is that for these sorts of molecular tests, they can't be done on tumor that has been decalcified. And for bone tumors, oftentimes chordoma is a tumor that involves the bone. The standard practice in most pathology departments is just like by default, it's going to be to decalcify the entire specimen. And that's going to result in that tumor being unusable or very likely unusable for these sorts of molecular tests that Shannon's describing. And so even though probably it's going to be unlikely you're going to find a doctor that's going to recommend doing the test right after surgery, thinking ahead and making sure that some of that tumor is saved in a non-decalcified fashion is going to be really advantageous if down the line you have recurrence and you need that tumor. So the thing to ask and really emphasize to the surgeon and make sure that the pathologist is on board with this, because sometimes it's just happening by default. It's not malice or it's not negligence. It's just, this is the standard workflow. And so unless someone at the hospital is really making an effort to deviate from that standard workflow, it's going to happen by default. So someone has to make sure that a portion of that tumor is set aside to be stored in a non-decalcified fashion. And so probably what that means is just saving an extra block, or if there's available tissue, an extra several blocks of formalin fixed paraffin embedded tissue that's not decalcified. And certainly if anyone has questions about that, you can follow up. It used to be the case that advanced molecular profiling would require either fresh or frozen tissue, but the techniques have evolved and improved very substantially over the last several years, such that most of the tests can be done on formalin fixed paraffin embedded tissue, which is great because that is kind of the standard processing method and storage method in pathology departments across the world. So there isn't a huge deviation that's required from the standard workflow, but the main thing is you just have to make sure that it's not decalcified.
All right, wonderful. Let's go over to Sue Brenneman. Sue, you want to unmute?
I forgot how to do it. It's been too long. I did have to ask for EGFR testing for our son for his recurrent tumors. And I asked for it one time and it didn't show up as being tested on his biopsy. And then he had another reoccurrence in a couple of months. And Dan Fried told me what words to ask for. It was some kind of phospho, GFR, Josh will know what it is. Testing that came back the next day. It was positive for EGFR, which now gave us something that we could use to a medication we could use to treat it with, which was FADNAB. But I did have to ask for that. I thought it'd be standard because Shannon says it's a pretty cheap test, but it doesn't, apparently is not.
Yeah, it's a really, really good point. So, so as a bit of context, so afatinib is an EGFR inhibitor. There's other EGFR inhibitors that are being tested for chordoma, like cetuximab, for example. But so all of these, but afatinib in particular, are very unlikely to work or to benefit patients if EGFR is not activated. However, we don't really know that for sure. So it's probably helpful information, but I think it's been difficult to make a kind of blanket recommendation or strong recommendation one way or the other, because we just don't have the evidence yet in chordoma to know whether indeed that is a marker of response or non-response for EGFR inhibitors. So in fact, that's one of the things that the afatinib trial and the ongoing cetuximab trial are trying to pin down, is whether EGFR status predicts response. But it certainly couldn't hurt to have that information. And again, because EGFR inhibitors are treatments that are used for a lot of other tumor types, many pathology labs will be equipped to look for EGFR phosphorylation in the tumor. But that's really probably something that is best discussed with an expert medical oncologist and a call for them to make as to whether it's warranted. Because if for one reason or another you're not a candidate for an EGFR inhibitor, or there's other things that might make more sense, you might not need it, or you might save it, that testing for when you are actually considering an EGFR inhibitor. But Sue, thanks for bringing it up, and great that you were able to get that.
Thank you, Sue. Next question is, what do we know about the best types of radiation or best type of radiation for chordoma, such as carbon versus proton therapy?
I can provide an answer, and then maybe Shannon can fill in some more. So, I think the jury is still out. There have been there's been limited head-to-head comparison between various modes of radiation or radiation modalities. However, I think what is becoming clear is that there are multiple radiation modalities that are effective. Proton's effective, carbon ion is effective, stereotactic radiosurgery using photons is effective in many cases. So I think what's perhaps more important than the modality is the way that it's delivered. So chordomas need very high doses of radiation, and in particular doses of radiation that are higher than can be tolerated with by a number of the critical structures that they're often near. So things like the brainstem, brain, arteries, colon, etc. So what's really important is being able to develop a radiation plan that can deliver a high enough dose of radiation to the entire tumor, if there's residual tumor, and or the entire area at risk, while sparing normal or healthy tissue. And in general, proton and carbon ion have the advantage of being extremely conformal. So you can have a very, very sharp fall off in the dose between tumor and adjacent tissue. But increasingly, highly conformal photon radiation is in many cases able to deliver similar or equivalent results. But it comes down to the individual's anatomy and the skill and experience of the surgeon, of the radiation oncologist in whose care you're in. So just because you're getting proton or carbon ion, if it's not in the hands of a highly experienced radiation oncologist, that still might not be optimal. So I think the key is, and I think what the consensus guidelines suggest is getting to an experienced center. And all of the centers that have experience treating chordoma, they're going to try to pick the tool that is best for the individual job at hand, whether that's carbon ion, if available, whether it's proton, whether that's a combination of proton and photon. And then there's further research that's ongoing to try to compare them head to head and see if in certain instances there is perhaps an advantage to one over the other. And I'll just mention, some people might know this, but carbon ion is really only available in a small number of locations in Japan and in Europe. There is a carbon ion facility that's coming to the US in the next few years. I think it's in 2027. And there's prospective trials underway right now in Germany, and I believe there's one planned here in the US to compare proton and carbon ion head to head. Shannon, anything you would add to that?
Yes. So one thing I wanted to add that was related to Josh, you talking about how conformal the radiation can be to deliver the high doses, and carbon ion and proton kind of having a little bit of an advantage there. From patient perspective on making some of these decisions, something that we encourage people to do is always, talk with the radiation oncologist about what side effects you can expect. Some radiation oncologists are very upfront and very specific. Something like, if we do this plan, there's a 20% chance that you'll lose hearing in your left ear, or something very specific like that they're able to tell you. It may not always be possible to be that specific, but if you haven't heard, if you're considering radiation plans and haven't heard about possible side effects, it's important to ask, just so that the doctor can tell you as much as they might know. They can't predict the future exactly, but just what the risks are, to understand what you might need to think about for the future. And there are short-term side effects from radiation that can happen immediately, depending on where the radiation is in your body. Skin irritation is a big one, and fatigue is a really big one as well while you're actually being treated. But there are some that can happen a few years later, and there are some things that can happen 5 to 10 years down the road, and we call those late effects. And as more chordoma patients are living longer, we're learning more about those late effects, and what they look like. But so, we don't know everything, and we can't necessarily predict the future, but it's a very good question to ask when you're considering your treatment plan.
All right, thank you. We're getting down to just the last couple of questions. So I have a question from Ed. I think I have one more from Richard and one from Renee offline. So if you haven't had your question answered yet, please feel free to pop it in chat quickly or raise your hand and I'll get to it before we wrap things up here. So next question, I'll go to the one from Renee. So Renee had nasopharyngeal surgery in May and then finished her proton treatments in September. She says her sense of smell and taste are still coming back. She's still struggling with quite a bit of mucus since the surgery and feels sinus pressure with headaches that she's taking Advil for. She's wondering if that's common for clival chordoma patients at similar points in their journey, and if you have, Josh, any advice for what she could do about it or how to overcome them.
Yeah, well, I can empathize a lot and share the struggle. In particular, after the most recent surgery, it's become really, really difficult to clear out the thick mucus that's kind of on the back of your nose, throat, etc. I see Adrian nodding along there. It's a real struggle and it definitely affects quality of life. I'd be curious what others have found is helpful, but I think there's a handful of things that I have found do make a big difference. Probably the number one thing is steam. So taking 20-minute, very steamy showers at least once a day, sometimes twice a day, and being pretty regular about that. Like if I miss a day, I find that I'm like set back and it's kind of much worse. That helps. Irrigating sometimes helps. I also have found that caffeine helps. I think that caffeine is a vasoconstrictor, so it causes the blood vessels in your nasal mucosa to constrict and kind of reduces some of the swelling, and I think then allows things to clear out a little bit. Personally, I have allergies that they were adult onset allergies that came about 5 or 6 years after my initial surgery, and keeping those under control makes a big difference. So I take, and this is not a recommendation per se, obviously talk to your doctor, but I take Flonase and Claritin, and personally that helps. So I think the combination of caffeine, steam, Flonase, Claritin, occasional irrigation, that kind of keeps things manageable. And if I don't do those things, then I'm struggling. But I would say Chordoma Connections might be a place to ask this question as well. I mean, I would actually be curious whether there's others on this call who have firsthand experience and any recommendations about this topic. Stephen, I see you've used NeilMed. That is it's a godsend. It's so helpful.
There are patients that I've talked with too who need to see an ENT, not necessarily their neurosurgeon, but an ENT every so often, just to kind of help pull some of that stuff out, that they can, kind of do a procedure that can help with some of that if it's really not coming through with these other strategies.
All right, thanks. Brenda, you want to go ahead? You have your hand raised. Yeah, go ahead, Brenda.
Hi. Yeah, thanks. Sorry, I'm from Argentina. My English is not that good. I got a question for you. Is it advisable to operate many times in the same place?
It really depends. I think in general, the conventional wisdom is that each subsequent surgery becomes more difficult because you're dealing with scar tissue, you're dealing with changed anatomy. If you've had radiation, the your ability to heal might be diminished. You might have radiation-induced tissue damage. So I think there's generally a limit to the number of surgeries that most patients can have. However, I would say that in principle, there isn't any maximum, and we are aware of patients who have had many surgeries. So I think that's it's really a case-by-case judgment call to make and very context dependent, and I think something to speak with an expert surgeon about. That being said, you're likely to get differing opinions from different surgeons around repeat surgery. I know there are various perspectives about the risks and the risk-benefit ratio, and so you might find yourself in kind of swimming in waters of relative data sparse situation, and so I think they're just leaning on the experience of your clinicians and really seeking out a care team that has a lot of experience, in particular dealing with recurrent chordoma is probably going to be pretty essential.
Question for you, Josh, from Ed. So this is a follow-up question to the needle biopsy question. He asked, is it common or have you ever heard of the spread to occur in the opposite direction of the needle? He says, I had an unexpected positive margin for a sacral tumor in the exact opposite direction of the biopsy needle path.
Interesting. I'm sorry to hear that. It's not something I've ever heard of. Shannon, have you?
No, I haven't. And I think that this is, I mentioned this in the chat. I think, we may not have heard that from someone before, but it doesn't mean that it hasn't happened. And there's many people that can be reached through the Chordoma Connections, our online community, and the Facebook group, that this is, questions like this come up sometimes. You post them there, and you do find that this has happened with someone else. But I don't think Josh and I would want to speculate on whether it could happen or how it could happen. It's interesting that it is in that particular location. But that's not something that I have heard of. But I really would encourage you, Ed, to post it in one of those groups if you're part of those, so that just in case there is somebody out there that has experienced something similar and might have something to share with you.
Yeah. Okay, great. I'm seeing just a couple of questions in the chat that are pretty specific to a patient's own case about what drug might be best for them next. And so if you're one of the folks asking that type of question, I would suggest following up separately with a patient navigator to be pointed in the right direction for those. And I know Josh and Shannon have pointed to the systemic therapy table as well. Thank you to people in the chat who are suggesting more help for people experiencing sinus issues. If you're interested in that, make sure you read up on the chat. I'm not seeing any. Oh, here, sorry, this is maybe the last one. Richard is asking, is there a possibility of bone fracture with high doses of radiation?
Yes. Yeah, insufficiency fractures are, just really small fractures that are common for sacral patients, especially in the bones of the pelvis. For spine patients, it could be the ribs, and there are some treatment options that involve kind of more or less filling up those fractures with a type of of cement to give you more stability, but also reduce the pain. There is some information about that on the sacral side effects, spine and sacral side effects page of our website. But so if that's happening to you, if you're starting to have pain that you had not had before, talking with whoever does your follow-ups to consider those types of, if those fractures are happening, is a good thing to do.
Okay, great. Any last questions? Richard, do you want to ask one more?
Let me unmute. Okay. So one of your first webinars, you said about the life expectancy of chordoma patients, Josh. And then I went to actually see my surgeon, and he said, well, with breast cancer patients, they have a lot of factors going in, and I know with chordoma patients, you got a less pool of people to go by and stuff like that. But I was just wondering if you can, is there a way you can break it down to like sacrum versus clavicle versus other areas of the spine, the life expectancy of that? Is there a breakdown on that, or do you have to group everybody together on the life expectancy?
Yeah.
Is there further breakdown?
Yeah, it's a good question. So the most comprehensive source of information on this question is it's a national cancer database. It's called SEER. SEER. It stands for Survey of Epidemiology and End Results Research, and basically it covers I believe it's around 40% of the U.S. patient population. They track every patient who's had a cancer diagnosis. And if you look to that database, now granted, it's always, you're always looking several years behind. So what's not reflected is the latest treatment technologies and care advances. But the latest evidence from SEER shows that across the board, across the entire population, the median survival for chordoma patients is about 8 years. There's a bunch of nuances there, and if you've had a larger tumor, that's a risk factor for shorter survival. If you have a smaller tumor, that's in your favor. Extent of resection, etc. So it's very difficult to extrapolate from that one population-based average to any one individual's case. There's so many individual factors and nuances that might influence what your individual life expectancy might be. And so it's really hard to speculate about that. Something that would be best to discuss with your doctor. It is definitely the case that if patients who get optimal care, so have a complete resection, if warranted, have radiation, are followed regularly, many of those patients are exceeding that median. So probably many of us on this call are in that camp, thank goodness. But it's also the case that there's some patients who have intrinsically more aggressive tumors, and even with the best care possible, they might have a rapid recurrence, they might progress rapidly, and we just don't know, unfortunately, at the moment, how to differentiate those at the outset to know which category you're going to be in. The closest thing we have, and what might help answer that question for more patients in the near future, is this FISH test that I alluded to earlier. And right now that's, again, just been employed for skull-based tumors. But at this moment, there's a study ongoing to determine whether that could also be prognostic for tumors of the sacrum and mobile spine as well. So perhaps in the next couple of years, you'll be able to know whether you're likely to, based upon that test, have a great outcome, or whether you have a more aggressive tumor that is likely to recur sooner and require more aggressive care.
All right. Everybody, this was so wonderful. We had amazing questions. Thank you so much to Josh and Shannon for fielding them so expertly. Hopefully you all have some more resources to follow up on after this. Again, the email to reach out to if you have additional questions is support@chordoma.org. But most of all, just thank you so much for being here. It was really good to see all of your faces and hear your questions. Shannon or Josh, any last words?
Thanks everybody for being here. Really good questions.
Yeah,
Thank you.
I want to echo that. This is energizing for us. Really good questions. We are always available, so please don't let this be the end of your questions. If you have any, feel free to reach out at any point. And I think just to come back to a concept that I touched on earlier, I think there's so much reason for hope right now. The pace of progress right now is like nothing we've seen before, and it's only going to accelerate from here. And that's because of everyone in this community coming together and rallying around this cause, and having agency in the outcome for those of us with this disease. So huge thank you to everyone for being a part of this cause, for being a part of this community, and for continuing to blow wind in our sails. We're looking forward to continuing to forge ahead and report back on additional progress in the months ahead. So until then, great to see everyone. Enjoy the day.